Neurology Quiz number 40. Describe clinical features of chronic inflammatory demyelinating polyradiculoneuropathy or CIDP. Which antibodies are associated with CIDP? CIDP is the most common chronic autoimmune neuropathy. Incidence is 0.35 per 100,000 and prevalence is 3 per 100,000. It results in damage to peripheral nerve myelin. 50% of patients have the typical CIDP, which presents as symmetrical proximal and distal weakness, large fiber sensory loss, and areflexia. The remainder have a CIDP variant such as MMN, DADS neuropathy, and MADSM neuropathy, etc. Typical CIDP presents with symmetric proximal and distal muscle weakness, length-dependent loss of predominantly large fiber sensation, and generalized loss of reflexes. Symptoms progress over at least 2 months, and the disease may have a progressive, stepwise or relapsing course. 15% of patients may have an acute onset resembling GBS. Unlike GBS, cranial nerves are usually but not invariably spared. Respiratory and autonomic involvement is also uncommon. Nerve conduction studies show features of acquired demyelination and along with the clinical features are most important for diagnosis. Findings include significant slowing of conduction velocities in the demyelinating range, prolongation of distal motor and sensory latencies, prolonged F-wave latencies, conduction block, and abnormal temporal dispersion. Misdiagnosis is avoided by careful attention to the clinical presentation and using electrodiagnostic criteria for CIDP, such as the European Federation of Neurological Societies criteria. CSF analysis shows albuminocytological dissociation with significant elevation of protein without increase in cells. MRI, if done, may show enhancing nerve roots, plexus, and peripheral nerves. First-line treatment includes intravenous or subcutaneous immunoglobulin, corticosteroids, or plasma exchange. Up to 70% of patients respond to one of these treatments. IVIG is usually the first choice. Initial dose is 2 grams per kilogram divided over 2 to 5 days. Maintenance dose of 1 gram per kilogram is given every 3 weeks, and up to 12 weeks of treatment may be required for maximum benefit. Prednisone can be given orally, 60 to 80 milligrams per day, or as an oral or IV pulse regimen. Plasma exchange is usually considered in patients refractory to IVIG and steroids. It may need to be repeated every 3 to 4 weeks. Limited data exists for use of agents such as azathioprine, mycophenolate, or rituximab, etc. in patients resistant to first-line treatments. 10 to 20% of CIDP patients have autoantibodies directed against paranodal and nodal proteins and are classified as nodo or paranodopathies. In the paranodal region, the antigens are NF155 in the myelin and CNTN1 and Caspr1 in the axons. In the nodal region, the antigens are NF140 and 186. NF155 positive patients present with chronic demyelinating neuropathy with distal greater than proximal weakness, positive sensory symptoms, sensory ataxia, tremor, autonomic dysfunction and pain, and sometimes with papilledema. The NF155 IG4 subtype is most specific. Caspr1 positivity is less common but may be associated with a similar clinical picture. Acute or subacute sensory predominant presentations and pain are associated with CNTN1 positivity. NF140 and 186 positivity is rare but can be associated with subacute demyelinating neuropathy and focal segmental glomerulosclerosis. The majority of antibody-positive cases have relatively poor response to IVIG with less than 40% improving. There are many reports of such cases responding favorably to rituximab. Other treatment considerations include plasma exchange and steroids. This is a figure showing the node of Ranvier and the paranodal region with antigens that are targeted by antinodal or paranodal antibodies.